Hello, everyone, and my name is Lana McAra. Welcome to Carb, Addict, now Carnivore. And today I am delighted to welcome Dr. Robert Cywes to the show. And it's really special for me because I live in the Jacksonville, Florida area, and I can't believe we are so close in vicinity. I'm usually interviewing people from all over the place.
Yeah, I'm actually in Jupiter, Florida right now, but my office and my background is up in Jacksonville. I was just there this past week, seeing patients up there. So exactly, we're closely connected.
Yeah, that's great. It's hard for me to find people that are in this arena, in this area. So I'm happy to meet anybody that I can, that's close by. So tell us a little bit about your background and your specialty, what you're doing in the world. I just love it. I can't wait to hear what you're going to say tonight.
Well, good. And I'm kind of part of a new wave of specialists out there. We're called metabolic health specialists. And in large part, if you look at the spectrum of diseases that we are most likely to die from, they're all pretty much self-induced. As a species, we humans have become very good, especially in first world countries, at conquering things that happen to us, maybe with the exception of trauma. But so infectious diseases, that kind of thing, we're really good at protecting ourselves from that, even environmental safety. But more and more, we induce harm to ourselves. We smoke, we drink alcohol, we use drugs. And if you combine all of those, they are in the minority of the dominant cause of our death, which is death by sugar. And what I mean by that is that chronic excessive carbohydrate consumption and our industry, our world, our pharma institution has become dominant in providing and advocating for the use of sugar and starch in our diet. But the bodies can't cope with that. The human body can't cope with that, and it breaks down. And the disease spectrum caused by that, depending on your genetics, is called metabolic disease, or the metabolic disease spectrums. And as a metabolic health specialist, we are able to identify, diagnose, and then manage or treat the spectrum of diseases. So it is a new fledgling specialty that combines aspects that all other specialists deal with in part. Your gynecologist is going to deal with PCOS amongst a myriad of other things. But PCOS, polycystic ovarian syndrome, for example, is a pure metabolic disease. And so we can specialize in the management of that. The big difference is that when you cause disease to yourself, medication doesn't fix that problem. There is no drug that can fix what you did to yourself. We can help with some ancillary things, but we really have to approach this in a relationship with our patients and from a behavioral perspective, from a nutritional perspective, as well as perhaps from a medicinal and surgical perspective. So we have all of those tools. That's what I do for a living. My background in this is somewhat interesting in that I started out in Toronto in a laboratory where we were looking at creating a model to study inflammation in the liver. And we needed to create a model that triggered inflammation very quickly in a biological way. So we would take out livers and mount them and introduce various naturally occurring substances into that liver. And the overriding premise in the late 80s, early 90s was that fat caused a problem. So when we infused various types of fat into the liver, hoping to create a vascular injury, an injury to the blood vessels, we found absolutely zero effect. Nothing. Bupkis. The vessels loved the fat. They just enjoyed them. The fat didn't stick to the vessels. Nothing bad happened. And that was so important, such an opposite reaction that we expected, because in those days, everybody thought that fat was, we demonized fat. We were lipophobic. And we tried a variety of different permutations of fat, polyunsaturated fat, saturated fat, and nothing worked. Nothing created inflammation. In fact, kumbaya, the liver was happy. We then looked at protein, no damage. In fact, the vascular endothelium thrived on protein. But when we gave the blood vessels, when we gave the liver what we thought to be the single most important beneficial substrate, which is sugar, because all, the brain needs sugar, or the body needs sugar, we within 3 hours could kill the liver by infusing sugar. So we realized very rapidly that an infusion of sugar together with insulin actually created the injury when infused in physiologically high levels. So the same kind of levels we see in diabetics. And it was that kumbaya moment that we didn't believe. How can this be possible at a time when everybody says it's the healthiest food and the fat is bad? But we created the injury, and we basically created diabetes in the laboratory, and it's very reproducible. But then we looked at, okay, how do we fix the damage that happens? Because once you get that inflammation from the elevated sugar, the blood cell lining of the liver gets inflamed, it attracts clots, and the clotting then plugs up the liver. So when we intervene with medications, where can we intervene at the earliest phase to reduce the acceleration or the promulgation of that clot? And statins didn't work because the lipids were the last layer of care, but the clot was already there. And the lipids were trying to fix the clot, not causing damage. And that was a big aha moment against the lipid heart hypothesis. But then when we realized that this was an early clotting inflammation and we intervened at a platelet level with medications like aspirin, we could then dampen that clot. And some of the early blood thinners were used, and we could get rid of that inflammatory injury. Not the injury of the sugar, but the clotting. And there's your heart attack and stroke. So that was the early work I did. But the bizarre part, because we're human before we're doctors, is we could not convince ourselves that what we were seeing was true. And that's the cognitive dissonance that we face. And it took me years of having this in the back of my mind, but everybody telling me that I'm wrong, that my data must be skewed. Something you've done with this experiment is wrong. But it was so reproducible. And just to put it in perspective, I know I'm monologuing a bit here, but to put it into perspective, the doctor that is most responsible for creating the glycemic index, a guy called David Jenkins, who's a professor of nutrition at University of Toronto, where I was training, he wrote in 1981 the glycemic index paper coming out of Toronto, which is the home of the discovery of insulin, Banting and Best, very, very famous diabetes center, who created the glycemic index, which is the current principle by which we manage diabetes, or at least by which they manage diabetes, not me. And that is where you eat some carbohydrates and you want to try to eat them so that they do this rather than this. So instead of using heroin, when you inject an opioid that's a little bit slower and you're less likely to turn blue and die. That was the principle. How about just not injecting heroin? And that it's literally that simplistic. And yet, if you believe heroin is necessary, you can't escape the concept of the glycemic index that is still the prevalent, mismanaged way in which diabetics are managed. But that's my backstory. And from there, we understood the ramifications of sugar, that it affected every one of the metabolic health issues, directly or indirectly, from obesity through diabetes to dementia to autism spectrum disorder, polycystic ovarian syndrome, you name it, it's affected gastroesophageal reflux disease, colon cancer, breast cancer. All of those things are directly or indirectly affected by what we do to ourselves. And we're just starting to unravel it. So that's my backstory.
Wow, that is so interesting. So explain the glycemic index. I know what that is, but I feel that that's a word that maybe some of the listeners may not understand.
The glycemic index is where you look, there's two things, the glycemic index and the glycemic load. The glycemic load is very easy. It's the total amount of sugar and starch that enters your bloodstream, that you consume. The glycemic index is the rate at which that sugar enters the bloodstream. So if you drink a glass of water that you've melted sugar in, that sugar is immediately available and it goes straight into the bloodstream at a very, very fast rate. So you get the surge of sugar. If you take, let's say, a potato or a piece of bread, those are complex sugars. They're like a necklace, a chain of things. So you have to break the chain down enzymatically before it can be absorbed. So the rate of absorption is not related to the ingestion of the sugar as it stands. It's based upon the rate at which the enzymes break the sugar down. So it's a much slower, longer rate of absorption. And the belief is that it's the spike in blood sugar that affects the diabetes. And in part, that's true. But ultimately, it is the entire glycemic load that persistently over time elevates insulin and doesn't allow homeostasis, which is the way the body works, which is feedback, ebb and flow. For every action, there's an equal and opposite reaction. Well, if the action is always happening, there cannot be a reaction. And that breaks the body. And depending on the organ affected, and every organ from the hair to the toenails can be affected, that results in the damage. And it just depends on where the body tolerates an elevated level of sugar.
So dumping sugar constantly on the body will eventually break it down. That's
excess sugar. Excess sugar in excess sugar in any space in the human body causes harm. And the body has a number of systems to protect each space. But it depends on your genetics as to where that cumulative effect happens. And that's the part that is difficult to reconcile, because, you know, if you smoke, some people get heart disease, some people get lung disease. Well, that's genetically predetermined, but the cause is smoking, which is not genetic. And the cause here is your relationship with sugar, which is a behavioral relationship. Whether you become diabetic or obese depends on your ability to clear certain spaces. If you can clear the blood vessels, you don't get diabetes, but you shove that sugar into your cells, your fat cells turn into fat, you become enormous. Whereas if you can't clear the sugar from the bloodstream, you build it up in your blood vessels, you have diabetes, which is more cardiovascular disease. If it all sits in your gut, you're getting intestinal, irritable bowel syndrome, acid reflux, colon cancer, diverticulitis, and a large part of the diseases of the modern era have been caused by our lipophobia, our fear of fat. I mean, just a simple little thing. Everybody says, oh, fiber is so important. But there's no fiber in breast milk. Okay, there's no, and babies don't explode because they can't poop. There's no fiber in breast milk, okay? So the concept, where does the concept of fiber come from? Well, when I was young, and I'm not young anymore, when we had constipation, our parents would use castor oil, cod liver oil, mineral oil. They'd use a fat, and the fat was a wonderful laxative. And anybody that's overeaten MCT oil, I can assure you, overeaten fat from time to time has had that little fecal seepage, as Ally or Orlistat, the fat blocker, called it. So fat is very effective as a laxative. However, in the lipophobic era of the 70s and 80s, we demonized fat. Oh, that's so bad, you're going to die of a heart attack. So we looked elsewhere for a laxative. And what do cows and gorillas, who are vegetarians, use to poop? They use fiber, insoluble cellulose. So fiber is a surrogate for fat to help our bowel function. But the problem is that the human intestine has lost the capacity to process fat in a symbiotic relationship with bacteria, funguses, and viruses in our gut. In fact, the only part of the body that still can, human body that can still do that, is the appendix, and mine's in a bucket somewhere. So what happens now is we ferment those vegetables in our gut, and that acidifies the poop. So when that stuff gets into the colon, that acid environment breaks down the collagen in the gut, and you get cancers, and you get diverticulitis, and you get irritable bowel from fiber, which is the very thing most gastroenterologists are going to recommend you take to avoid those problems. That is how upside down our world has become. So you only accommodate for one thing, you create harm on another front.
Yes, this makes so much sense. So what was it that brought you around, you know, from doubting the science to now embracing the science?
Well, I'm a surgeon clinically, and I'm actually a board-certified pediatric surgeon. So this was in Nashville in the late 90s, and I was operating on kids, taking their gallbladders out. Now, no child should have cholesterol gallstones. It is it's a metabolic disease. It's a disease of carbohydrate excess. We know that now. But in those days, I was operating on these kids in Nashville, and you'd have a 12, 13-year-old kid who was 300-400 pounds, and I'd just taken out their gallbladder, and I'm sitting in their room, and we thought that the gallbladder was it is cholesterol, but we thought it was from eating fat, but now we know differently. Nevertheless, you go into their room afterwards, and you think, okay, this kid had gallstones because he was eating so much fat. But when you look at what he's eating a Big Mac with fries, he's drinking, big 2 or gallon size thing of Coke. It's all sugar and starch. If 90% of what he's consuming is sugar, and less than 5 to 10% is actually fat, how can the fat he's not eating be causing this problem? It was so obvious. And then I personally had a little issue with obesity. I've lost 106 pounds as I'm sitting here. So I also recognized my own propensity, not toward food, but toward sugar. And that I can eat an endless amount of carbohydrate, but I cannot eat an endless amount of protein, especially when it's with fat. Fat is your satiety hormone. We know that fat is innocuous in the liver, and it stops you from eating. But sugar, the more you eat, the more you consume. You know, water has a stopping point when you drink it, but alcohol doesn't. You have to consciously stop drinking alcohol. And the same is true for sugar, especially high glycemic index sugars.
Yes. So when did you make that shift in your thinking? How long ago was that?
We're talking about the mid to late 90s, when I combined my research with my own experience and with that in the patients I was seeing, where it just didn't make sense. But if everybody is saying this and you see the opposite, that can be very challenging. And I, as a surgeon, did not have a very good way of confronting the establishment, especially at a university like Vanderbilt, where it is entrenched. There's a lot of dogma, there's a lot of tradition. And the problem with tradition is that it defies change. And that was very, very challenging. So I moved to Florida, started out with another company, and then went out into private practice where I could have autonomy over the way I managed my patients. And believe me, I was filled with self-doubt, because how can I, simple little old me, who's a surgeon so I don't have to think, how could I be right and everybody else is wrong? It doesn't hold muster, and it still doesn't. After 23, 25 years of doing this, I still have that imposter syndrome. This can't be right. But the beauty was that every single patient, including the number one patient, which was myself, every day proved that we were right. Every patient that is no longer diabetic because they're eating fat, every patient that has lost a few hundred pounds because they're not eating carbohydrates, every polycystic ovarian syndrome patient who now is pregnant, just had that last week again, and all the time, every cardiovascular patient that improves their cardiovascular disease, it resonates from every perspective. Cognitive impairment is reversed, not Alzheimer's, but the earlier cognitive. So many results that you can't unsee this. You question it all the time, but you can't unsee it. So every day I see evidence that is proof. And the flip side is there is absolutely no proof that fat makes people fat. So it's the absence of proof of the dogma that society associates with harm, and then the presence of a transformation that is so positive in terms of transformation of health, of illness into health, that really is, that duality is so important. But it's still not accepted by, and I guess, you know what, Lana, it isn't. The physicians, as I said earlier on, are human. This is a narrative that is very, very heavily driven by industry. The vested interest is industry. And it's not just the health industry. It's not just the healthcare providers. It's not just the pharmaceutical companies. It's the manufacturers, the tobacco manufacturers, the Coca-Cola manufacturers, the cereal manufacturers for the fluoride in our drinking water. All of those are industrial schemes, nefarious industrial schemes. And I'm not a conspiracy theorist, although there's a lot of conspiracy here, that deflected us away from their harmful product. And that is the story of healthcare in the modern era, where industrial beliefs and industrial slogans have become part of healthcare law. And then the only other comment is that I was raised in an era of physiology, where we studied how the steps of how the body functions. And physiology is always true, whether it is how the body functions optimally or pathophysiology, the steps that happen when the body fails. That's what I was trained in. Circa 1990, when I was in the lab, the big universities made an intentional pivot away from physiology and basic science toward epidemiology, outcome measures. And the problem with outcome studies is they will say whatever you want them to say. Red meat causes cancer. Oh, sorry, causes diabetes or cancer, both of them. I just did a YouTube video proving that water causes cirrhosis of the liver. Okay? But, and you know what? It is absolutely true. If you ignore the whiskey that's in the water, then water definitely causes cirrhosis. In exactly the same way, a hamburger, lasagna, pepperoni on a pizza causes diabetes. If you ignore the pizza, if you ignore the lasagna, if you ignore the burger, the fries, and the sugary drink, then clearly the meat must cause those. And that is promulgated by various people with agendas that are financially driven, religiously driven, or driven by the industry that they work for. And that's the narrative that we struggle with.
Yes, yes. I started the carnivore lifestyle because I was having so many stomach aches. And I met a friend who was doing the carnivore, way of eating. And she was so good. She looked so well. And she had diabetes that was reversed and all this. And I thought, well, I'm just going to try it for a month. I'll try it for a month. And maybe then I can start adding back food to see what's causing my stomach aches. But I felt so much better. I mean, within 2 weeks, I felt like a new person. My knee wasn't no longer hurting, and my brain cleared up. My anxiety went almost down to zero, and I had high anxiety. And I started to look at YouTube channels of people that were eating this way, and I started hearing the testimonials and stories of how much better people were feeling. And I thought, this is real experience. It's not a test on a piece of paper. And I think I need to pay attention. And I decided I'm going to stick with it. And it's been 10 months now. So it's just so refreshing to me to hear someone with training say that what we are experiencing is actually, I mean, it's not a fluke.
Well, I think there's a physiologic basis for it, with a caveat that while carnivore is enjoyable, it is not necessary. In other words, carnivore, now for someone with GI issues, that's probably the most relevant place to limit plants, because the plants, the protein in plants are very inflammatory to the human gut. I've got a gut of steel. I've really never had intestinal problems. So it doesn't matter for me whether I'm eating plants or whether I'm eating animals. However, ultimately for everybody, it's our relationship. It isn't carbohydrates, but it's our relationship with carbohydrates that is broken. Mm-hmm. So there's a subset of people where GI inflammation is their dominant symptomatology. And for Crohn's disease, ulcerative colitis, we've noticed tremendous impactful benefit from carnivore. But I think in the real world, which I work in, carnivore is not always nirvana. Carnivore is not better for most people. It is not eating carbohydrates that's the starting point. And I think there is an evangelical push to go carnivore for a lot of people. And if you're not, you kind of don't belong to our tribe. We've chosen to be carnivore primarily because my dog that's lying down over there won't eat salad at the end of the week. So we have to throw it away, but he will eat leftover hamburgers. So there was a pragmatic, and we enjoy eating it that way. But I think it excludes so many people who are comfortable eating plants, comfortable being omnicarnivores. So I think there are specific indications where I'm going to push carnivore, either by preference or by certain disease entities, but it's too narrow a spectrum for everybody, if that makes sense. Mm-hmm. And sustainability is a challenge. And then also, there are people out there that just find that it's too austere, it's too tough. So instead of abandoning everything, what we've got to look at is what are the crucial things. And it's changing your relationship with use of sugar and starch, binge eating and snacking as a substance abuse problem. And then finding something that you can do that is compatible with adequate nutrition without involving carbohydrates. Lana, the only thing an alcoholic should do is quit drinking alcohol. Nobody tells an alcoholic what they should drink, but everybody loves to tell fat people what they should eat. And that's a vestige of the diet mentality. The reality is it's changing our relationship with sugar and starch and then adding fat to our food to substitute carbohydrates, primarily because nobody eats a massive amount of protein. The amount of protein we eat, it can be too much or too little, but it's very, very tightly regulated around 18 to 25% of our diet. It's the 75 to 80% that is either carbohydrate dominant or fat dominant where we can create the shift. And then the ancillary vehicles don't matter. If it goes in your face in the way of a plant, maybe an olive oil versus a butter, it depends on your tolerance. So we personally are carnivore. My son has been raised on a plant-free diet. At school, you don't say carnivore in Florida because I'll go to jail. DCF will come and arrest me. But he's on a plant-free diet because he is allergic to gluten.
Yes.
Again, the euphemistic approach, unfortunately, in this era of over-the-fence judgmentalism has been a big problem.
Oh, yes, absolutely. It has been so disempowering because everyone's afraid to say anything. They're afraid the wrong word might slip out. So the reason I started my channel, Carb Addict Now Carnivore, is because I realized that my addiction to carbohydrates and sugar, but also other carbohydrates, was off the chart. I'm totally addicted to any kind of sweet taste or starch, especially potatoes. So when those cravings hit me, I was shocked at how much it just overwhelmed me completely. So what would you suggest for people that are having this addiction and we're in the throes of it? Is there any particular way to approach it, or does it ever go away?
So it's a good question. I think the big conversion that we try to help most of our patients to do is most of our patients are already experts at failing weight loss programs, which is where you change what you eat. And the reality is, if you're looking to lose weight, any diet will work. Any form of caloric restriction works to lose weight, but it doesn't in any way, shape, or form address the cause. So before we change anything, we want our patients to go back and review with an objective mindset their daily pattern. And, for example, when I was fat, I'd wake up in the morning, go over to the fridge and open it and get something to eat. It was usually cereal or some toast or whatever, or some jam on a piece of bread or whatever it was. It was always a carbohydrate, but my habit, and this is what people don't understand, it's not just carbohydrates. There is an emotion management system related to certain habits. So if in the morning you get up and the first thing you do is you get your ashtray and you take out your cigarette, you tap it twice, you have your favorite, there's a ritual to which people smoke. And there was a ritual to which I went to the fridge, opened it in the morning, had my breakfast. There was a ritual to which I had my M&Ms and Coke in my office that I'd go and snack on between patients. There was a ritual by which, as soon as I got home at night, I came indoors and immediately went to the fridge, knowing that dinner was being made, but I went to the fridge not for food, but for emotional restitution because my drug was there. There was a ritual, I've just had dinner, I'm full, of going to the fridge and getting something to eat, a little snack in the evenings as I relax to go to bed. So the first step is contemplation. In addiction management, it's always contemplation, awareness, and ownership, not of carbohydrates, but of the entirety of the little quirks and the little pathways and patterns that you have that are part of your emotion management system. And it's the process as much as the substance. And everybody has a ritualistic way in which they eat. The second part, so once you have that ownership, you then also want to understand, particularly with carbohydrates, where they are hidden. Because the world out there will tell us an apple is very healthy and a donut is bad. And it's true, an apple is very healthy if you're a skinny person who doesn't have a problem. A glass of red wine is very healthy for me. But if you're an alcoholic, I don't care how healthy it is, it's on the no list. So figuring out where the sugar and starches are, what your behavior pattern looks like, And then realizing that everything you do, carbohydrates and that quirky behavior pattern, is all vitally important to you. It's hugely beneficial. So if you just remove these things, you're leaving a massive void in your life. If you say, I'm not going to eat carbohydrates, you're depriving yourself of your entire existence. You're killing your best friend. Because when you drink a lot of alcohol, they don't call you somebody who drinks a lot of alcohol. They don't call you the liver disease patient or the DUI patient. They call you an alcoholic. It defines who you are, because it is every aspect of your life. Every aspect of your being is engaged in alcohol defense, protection. Think it's who you are. And the bizarre part is you're a crackhead, you're a heroin addict, you're a smoker, but they call us fat. They call us by the consequence, because they don't understand what the substance is. So you really want to reconcile with that and have ownership. And you don't have ownership of, aha, now I understand who I am. And if you don't have ownership, you cannot choose to be free. The other big thing about addiction, I can eat ice cream anytime I want to. I can go out and get some M&Ms right now, okay? I'm not deprived of them. I have chosen not to. This is my choice. I don't have to. And diets will say, you can't eat this, you're not allowed to have that, you got to measure this out. They're asking you to tightly control and live in a very deprivational environment. It's not sustainable. I am empowered by what I do. I have chosen to take my dog for a walk for breakfast instead of go to the fridge. It's removal and replacement. That going to the fridge in the morning is sacrosanct, but now it's a walk with my dog. And I had to force myself to do that until over time, it's just become who I am. So recognizing the behavior and slowly over time, replacing it. You didn't suddenly become fat. You're not suddenly not going to have a fat head. It takes behavioral change, takes time and reinforcement, and it basically lasts or should endure for the rest of your life. Every day is a challenge. That's what people don't understand. And the kumbaya people, oh, I went carnivore last week and I'm feeling, that's nice, okay? So you met somebody wonderful, but you're not married to them. You're not dealing with all the issues of living with somebody for 25 years in a marriage. But that's what this relationship has to become. And of course, you're going to suck at it to begin with. Of course, you're going to struggle with it. But you learn. And that's addiction management, as opposed to here's your diet, off you go.
Mm.
The other part also, just which people don't understand, is that when you crumple up the cigarettes and throw them away, I quit smoking. There's a psychological dependence on the nicotine, but there's also a physiologic dependence. And, I never think of a cigarette because I've never smoked and I have no nicotine in my bloodstream. But for every smoker, as your nicotine level subsides, there's a physiologic desire by your body for that nicotine, not just a psychological driving force. And the same is true with carbohydrates. When you are sugar dominant and your insulin levels are elevated, that hypoglycemia, it makes you miserable. And all you desperately want to do is eat something sugary to prop that up. It takes a while to eliminate the nicotine from your body. It takes a while, even longer, to become fat adapted and get rid of the insulin carbohydrates. It doesn't happen like this. So the worst thing you can do is to stop everything right away. You've got to rebuild the engine. And biology doesn't work overnight. So a large part of this is being the tortoise, not the rabbit. Mm-hmm. You know the fable. And too many people are locked into diet methodology. I'm going to change what I'm eating because I want to lose weight. They don't understand the behavioral transformation. And then it just becomes, oh, I did keto. How do I know absolutely that that's true? You're old enough to know this. A huge number of people did extremely well on Atkins and then gained it all back because Atkins was a diet. It wasn't a behavioral change program. It was wonderful. It worked really well. People lost a lot of weight. Their health got better, and then they crashed and burned because they were still the same person. They didn't change who they were.
Yes.
And this time we have to do it a bit differently. We have to approach it differently. And we're still, even in our own community, struggling to make the transition from what to why.
Yes. That makes so much sense. To over time change your habits, introduce new habits, lay off the old habits. And also with the food, introduce substitutes and just keep it rolling. Yeah, that really makes a lot of sense.
Just along those lines, I personally have been doing this for 23 years. I lost my weight 23, almost 24 years ago. I'm still working at it. I'm still evolving as a human being. And I hope one day I will die. And in the morning of the day that I die, I'll ask myself, what am I going to do today to advance this cause? So it is an ongoing evolution. There's no such thing as maintenance. And that's another problem. People lose the weight. Ha, ha, ha. Look, I'm good. I'll just have one little taste at Thanksgiving. I'll just have one slice of Christmas cake. Well, if you were an alcoholic and that was a beer.
Yes. Yes, absolutely. That's the thing. That's the point right there that has kept me going, because I had such intense cravings way back at the beginning that when I see something like that, which would be tempting, and my addiction was ice cream. I would eat an entire 2 quarts of ice cream if it was in the fridge. I wouldn't eat it all at one time, but over the next 2, 3, 4 days, I'd be eating that, over and
But,
over
Lana,
again.
you got to be careful with that because, and again, I understand where you're coming from. But if you smoke and you smoke Camel and you're out of Camels, but somebody offers you a Marlboro, you're not going to say, oh, no, 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 thank you. I just smoke. I don't smoke Marlboro. Of course, you're going to smoke. Yes, our predilection, mine was Coke and M&Ms and ice cream on top of that. But you give me an apple, you give me something else, I'm still going to use that for the buzz effect. So many people on the keto diet side say, oh, you can eat some blueberries, you can eat some berries. As Eric Westman, my good friend Eric Westman says, those are just late little baby fruits. So if you were an alcoholic, the equivalent is that little bottle of vodka on the plane. That's okay to drink, but don't get the big bottle. No, baby fruit are as much a trigger. And again, those are the steps forward away from this being a diet toward this looking at your relationship with it. And that's the issue. And there's no way I can have blueberries in my fridge because I'm doing drive-bys.
Yeah. Yeah, absolutely. Yeah. Wow,
So
this has been
it's a
amazing.
distinction. It's sophisticated. It's evolved over time. And I know that a lot of people are going to sit there, oh, you don't understand. Well, it's different. Okay. Let's see where you are. Because everybody does well to begin with. You look at Ozempic, which is a drug that everybody's using to treat insulin resistance, which is the only drug effectively known to help with the disease that's caused by chronic excessive carbohydrate consumption. It helps with insulin resistance. It's appetite suppressing. There's a lot of beneficial side effects. But when you use it as a monotherapy, everybody loses weight. Everybody's diabetes gets better while they're on the drug. But if you look at all the trials, as soon as they stop, even if they go onto a placebo, they all gain their weight back. By 48 weeks, the majority of people have gained most, if not all, of their weight back. And by 2 years, they're heavier than they were when they started. So this one drug is being used as an endpoint therapy rather than as a tool on a journey.
Right.
And then it gets maligned because it causes all these symptoms. Well, if you're an alcoholic and I give you antabuse and you drink alcohol, you're going to feel like crap. So if you're eating carbohydrates and overeating on Ozempic, you're going to feel like crap. That's the medication doing its job. If you're eating salad and now you're eating less salad and losing weight, well, of course your muscles are going to waste away because you don't have any source of protein going in. So all of those things need to be managed in a multimodal way, as does addiction.
Yes. It's not one size fits all, and it's not just one thing. It's
Exactly.
complex. Yeah.
It's a complex disorder, and it's an evolving change. You don't change on a day. There's a woman that you may know of who's an absolute hero for me, and we are very parallel in our management, by the name of Brene Brown. If you haven't heard of Brene Brown,
Oh, yes.
Brene Brown, Google her, see what she does. But she's got a beautiful way of helping people to make behavioral changes. And there's something called 10 guideposts to wholehearted living, which is just a beautiful 10 things. But the way she phrases it is so good. And it's so important in addiction management. She doesn't say, stop this, do this, which is what a diet says. Don't eat this, eat this. She says, let go of and cultivate. Let
Mm.
go of this behavior and cultivate this one. In other words, it's a slow process of evolving, letting go of something, and then slowly challenging yourself until this becomes what you do. Let go of the fridge and cultivate a walk with your dog. It evolves over time, and that defines, that phraseology defines addiction management.
That is so beautiful. Because it is manageable and sustainable. It's doable. You can actually do that rather than getting on the wagon, falling off, climbing back
And
on,
that's the
falling
point
off.
is, when you're cultivating something, you're working at it. When you letting go of some days you're holding on to it, some days it's easy to let go, but it's an evolving transformation.
Mm-hmm.
And that really defines behavioral change. And she phrases it so well. And that is a foundation of how we approach our patients. But it's a transformation. It's slow, steady change. And it's like peeling the onion. Every layer you go, the deeper it gets. But there's always another layer. And it becomes sweeter and sweeter the more confidence you build up in that behavioral change. But there's always another layer.
Wow. This has been tremendous. Just so much great information. I really appreciate you taking time out of your busy day to talk with us. Is there anything you'd like to leave us with before we wind up here?
Well, you notice that we didn't talk about food. And again, it's because alcoholism has nothing to do with hydration, and obesity has very little to do with nutrition. Nobody dies of alcohol deficiency, and nobody dies as long as they got water, and nobody dies of carbohydrate deficiency as long as they got real food. So it's important to understand that. But our society in our lifetime will never, ever get this because all the economic, all the industry, all the political, all the evangelical religious forces are against us understanding this. So this is where you as an individual have to be introspective, look at yourself, and decide for yourself what you want to do. I'll give you information that a statin may not be such a good thing, while everybody else is telling you you're going to die of a heart attack if you don't take a statin. But I'm not going to come over to your house and put it in your mouth or slap it out of your mouth. Based on the evidence, you decide for yourself, or at least do the experiment. And this is always an experiment. Life is an experiment. Design it and be aware of the results. And if the results aren't there, find something else. If the results are there, continue along this pathway.
Beautiful, beautiful. Thank you so much for the time. And we will be putting your links and so forth down below. If there's anything particular that you would like me to post, just email it to me and I'll be sure to put it there, and I'll let you know when we go live, probably in around 2 weeks or so.
Perfect. I think the most important thing is just the place where they can see the information in little pieces is our YouTube channel, is our Instagram channel. That's kind of our support group.
Mm-hmm.
We don't monetize it. We don't depend on it fiscally. It is not directly. I mean, it's a way that our patients refer themselves to me. So that's how we benefit. But I'm a practicing physician, and that's the way I don't make money.
Mm-hmm.
Awesome. So, and I say that specifically because they're siphoning away our livelihood. But so be it.
Yes. Yes. Thank you so much.
Good.
And thank you for being with us. We'll see you next time. Bye now.
Take care.